The landscape of dementia care reveals a complex tapestry of gender-based differences that extend far beyond simple diagnostic statistics. Recent groundbreaking research examining the healthcare trajectories of millions of Medicare beneficiaries has uncovered striking disparities between men and women following a dementia diagnosis, challenging previous assumptions about who bears the greater burden of this devastating condition. A paradigm shift in understanding dementia burden. For decades, the medical community has observed that women represent a disproportionate percentage of individuals living with dementia. This observation led to widespread assumptions about the relative severity and progression of the disease between sexes. However, a comprehensive analysis of over 5.7 million Medicare beneficiaries has fundamentally altered our understanding of these dynamics, revealing that the apparent female predominance in dementia cases masks a more nuanced reality. The research conducted by Dr. Jay Lusk and colleagues at the University of North Carolina in Chapel Hill represents the most extensive evaluation of nationwide healthcare patterns among men and women with dementia ever undertaken in the United States. Their findings illuminate a paradox that has important implications for clinical care, family planning, and healthcare policy. While more women may live with dementia, men experience significantly worse outcomes following diagnosis. Mortality patterns, a tale of two trajectories. The most striking finding from this massive dataset concerns mortality rates following dementia diagnosis. When researchers examined crude one-year mortality rates, they discovered that women with newly diagnosed dementia had substantially better survival prospects than their male counterparts. Specifically, 21.8% of women died within the first year of diagnosis, compared to 27.2% of men. A statistically significant difference that persists even after accounting for numerous confounding variables. This survival advantage for women remained robust, even when researchers controlled for factors that typically influence mortality risk, including chronological age, racial and ethnic background, socioeconomic status as measured by Medicaid dual eligibility, overall medical comorbidity burden, and access to healthcare resources. After these comprehensive adjustments, men still faced a 24% higher risk of death following dementia diagnosis compared to women. The implications of these mortality differences extend beyond mere statistics. They suggest fundamental biological, social, or healthcare-related factors that influence how dementia progresses and how patients respond to available treatments and interventions. Understanding these differences could prove crucial for developing more personalized approaches to dementia care and for helping families prepare for the challenges ahead. Healthcare utilization, differential patterns of care. Beyond mortality outcomes, the research revealed significant disparities in how men and women with dementia interact with the healthcare system. These differences in utilization patterns provide valuable insights into the distinct challenges and needs faced by each group throughout their disease journey. Hospital admissions represent one of the most significant areas of divergence. Women with newly diagnosed dementia experienced all-cause hospitalizations at a rate of 46.9%, while men faced hospitalization at a rate of 50.5%. Even after adjusting for demographic and clinical factors, men retained an 8% higher risk of hospitalization compared to women. This pattern suggests that men with dementia may experience more acute medical crises, have different symptom presentations, or face challenges in community-based care that necessitate hospital intervention. The higher hospitalization rates among men extend to specialized services as well. Men with dementia were more likely to require neuroimaging services, suggesting either more complex diagnostic workups or greater monitoring needs for disease progression. They also experienced higher rates of hospitalization specifically for neurodegenerative disease diagnoses, indicating more severe or rapidly progressing neurological symptoms that required acute medical intervention. Perhaps most poignantly, men with dementia were more likely to utilize hospice services, which aligns with their higher mortality rates and suggests that their disease trajectory may be more aggressive or that end-of-life care needs arise more frequently or earlier in the disease course. Unraveling the paradox: why more women live with dementia, despite better outcomes. One of the most significant contributions of this research lies in resolving a long-standing puzzle in dementia epidemiology. Previous population-level studies consistently showed that more women than men die with a dementia diagnosis, leading to questions about whether this reflected higher disease incidence, worse outcomes, or some combination of factors. The current findings provide a definitive answer. Men actually experience worse outcomes after dementia diagnosis, which means the higher burden of dementia among women in population statistics reflects the fact that women are simply more likely to develop dementia in the first place, rather than experiencing worse outcomes once diagnosed. This revelation has profound implications for how we conceptualize dementia risk and burden. It suggests that preventive strategies might need to focus more heavily on understanding why women develop dementia at higher rates, while treatment and care management approaches might benefit from recognizing that men face more aggressive disease progression and higher mortality risk once diagnosed. Demographic and clinical characteristics, painting a detailed picture. The massive scale of this study, encompassing nearly 6 million Medicare beneficiaries, provides an unprecedented opportunity to examine the demographic and clinical characteristics that distinguish men and women with dementia. The study population included approximately 3.3 million women and 2.4 million men, with participants followed for up to 8 years after their initial dementia diagnosis. Interestingly, women received their dementia diagnosis at a slightly older average age of 81 years compared to 79 years for men. This age difference, while modest, may reflect important biological or social factors that influence when dementia symptoms become apparent or when individuals seek medical evaluation for cognitive concerns. The types of dementia diagnoses also varied significantly between sexes. Women were substantially more likely to receive a diagnosis of Alzheimer's disease, which represents the most common form of dementia and typically follows a somewhat predictable progression pattern. Men, conversely, were more frequently diagnosed with Parkinson's disease dementia or received unspecified dementia diagnoses, suggesting either different underlying pathological processes or potentially more complex diagnostic presentations. Comorbidity patterns, the broader health context. The research revealed striking differences in the broader health profiles of men and women with dementia, which may help explain some of the observed differences in outcomes and healthcare utilization. These comorbidity patterns reflect the complex interplay between dementia and other age-related health conditions. Women with dementia showed higher rates of certain mental health and vascular conditions. They were more likely to have comorbid anxiety and depression, which could reflect both biological predispositions and psychosocial factors related to disease awareness and coping mechanisms. Women also had higher rates of peripheral vascular disease, which affects blood circulation throughout the body and may contribute to cognitive decline through vascular mechanisms. Men, on the other hand, displayed higher rates of cardiovascular and renal conditions that typically carry more immediate mortality risk. They were more frequently diagnosed with cerebrovascular disease, coronary heart disease, myocardial infarction, and kidney disease. This pattern of comorbidities may partially explain the higher mortality rates observed in men with dementia, as these conditions can lead to life-threatening complications and may accelerate overall health decline. Implications for caregiving and family dynamics. The differential patterns of healthcare utilization between men and women with dementia may reflect important differences in behavioral symptoms, caregiver resources, or social support systems. These factors play crucial roles in determining whether individuals with dementia can be successfully managed in community settings or require more intensive medical interventions. Research has long recognized that behavioral and psychological symptoms of dementia can be among the most challenging aspects of the disease for both patients and caregivers. The higher hospitalization rates among men might suggest that male patients experience more severe behavioral symptoms, have different manifestations of the disease that are more difficult to manage at home, or face gaps in available caregiving support. Alternatively, the differences might reflect varying caregiver responses to similar symptoms based on gender expectations or comfort levels with managing different types of challenging behaviors. Understanding these dynamics could inform the development of more effective support programs for caregivers and more targeted interventions for managing dementia symptoms in community settings. Biological and hormonal factors, potential protective mechanisms. The observed survival advantage for women with dementia raises intriguing questions about potential biological mechanisms that might confer protection against the most severe consequences of neurodegenerative disease. Researchers have hypothesized several possible explanations that warrant further investigation. One compelling theory centers on the potential protective effects of having two X chromosomes. Women possess two copies of the X chromosome, while men have only one paired with a Y chromosome. If certain genes on the X chromosome contribute to brain health or resilience against neurodegenerative processes, having a second copy might provide a biological advantage that helps women better withstand the effects of dementia. Another area of active research focuses on the potential neuroprotective effects of estrogen exposure throughout the lifespan. Women experience decades of exposure to estradiol and other estrogens during their reproductive years, and these hormones have demonstrated various neuroprotective properties in laboratory studies. Estrogen may help protect against ischemic vascular damage, which can contribute to both stroke risk and certain types of dementia, and may also provide direct protection against the pathological processes underlying Alzheimer's disease. However, these biological hypotheses must be balanced against the recognition that men face higher rates of various life-threatening comorbidities, which may contribute to their worse outcomes through non-neurological pathways. The interaction between dementia pathology and other age-related diseases may create a particularly challenging clinical scenario for men with dementia. Clinical practice implications toward more personalized care. The findings from this large-scale analysis have immediate implications for clinical practice and care planning. Healthcare providers caring for patients with dementia should consider these sex-based differences when discussing prognosis, planning care strategies, and counseling families about what to expect in the disease trajectory. For male patients with dementia, the higher mortality risk and increased likelihood of hospitalization suggest the need for more intensive monitoring and possibly more aggressive management of comorbid conditions. Healthcare teams might benefit from implementing more frequent follow-up visits, closer monitoring of cardiovascular and renal health, and earlier discussions about advanced care planning and goals of care. The higher rates of hospice utilization among men also suggest that end-of-life care planning should be initiated earlier in the disease course for male patients. This doesn't mean assuming worse outcomes, but rather ensuring that patients and families have adequate time to consider their preferences and make informed decisions about care goals. For female patients, while the overall prognosis may be better, the higher rates of anxiety and depression suggest the need for attention to mental health support and psychosocial interventions. The longer survival times may also mean that families need to prepare for extended periods of caregiving and should consider the long-term sustainability of care arrangements. Research limitations and future directions. While this study represents a remarkable achievement in scope and scale, the researchers appropriately acknowledge several limitations that should be considered when interpreting the findings. The analysis relied on administrative claims data and diagnostic codes, which may not always accurately reflect the true clinical picture or may miss important nuances in diagnosis and disease severity. The diagnostic codes used to identify specific dementia subtypes have not been validated against comprehensive medical record review, which means that some of the observed differences between men and women might reflect diagnostic practices or coding patterns rather than true biological differences. Future research using more detailed clinical assessments and biomarker data could provide additional insights into these patterns. The study was also limited to fee-for-service Medicare beneficiaries in the United States, which means the findings may not apply to individuals with other types of insurance coverage or to populations in other countries with different healthcare systems and cultural contexts. Conclusion: a new framework for understanding dementia. This groundbreaking research fundamentally alters our understanding of how dementia affects men and women differently. Rather than viewing dementia as a uniformly distributed burden, we now recognize a complex pattern where women face higher risk of developing the disease, but men experience more aggressive progression and worse outcomes once diagnosed. These insights demand a more nuanced approach to dementia care, research, and policy development. Prevention efforts might focus more intensively on understanding why women develop dementia at higher rates, while treatment protocols could be adapted to address the more aggressive disease course often seen in men. As our population continues to age and the burden of dementia grows, understanding these sex-based differences becomes increasingly critical for developing effective strategies to reduce suffering and improve outcomes for all patients facing this challenging diagnosis. The path forward requires continued research, improved clinical awareness, and healthcare policies that recognize and address the distinct needs of men and women throughout their dementia journey.